Welcome to Aspire's ED Talk on optimal endometrial preparation for frozen embryo transfer. As vitrification methods have improved over time, frozen embryo transfer has become a viable alternative for transfer. Controlled ovarian stimulation has been known to cause problems with implantation potential, and therefore with FET giving rise to many higher number of pregnancies, many centers have now started using frozen embryo transfer for all their cycles. And to discuss this, we are going to have a discussion with Professor Richard Paulson so that we can discuss what is the best option for preparing the endometrium for frozen transfers. So let's welcome Professor Richard, whom I popularly is known as Rick. And Richard Paulson holds the Allied Tutor Chair in Reproductive Medicine and is Professor and Vice Chair in the Department of Obstetrics and Gynecology at the University of California. He's the Chief of Division and Director of Fellowship in Reproductive Endocrinology and Infertility. He received his MD degree from UCLA and an MS degree in Biostatistics and Study Design from USC. And Dr. Paulson has been the past president of the American Society of Reproductive Medicine, of the Pacific Coast Reproductive Society, the Society for Reproductive Endocrinology and Infertility, and the Los Angeles OB/GYN Society. He's the editor-in-chief of Fertility and Sterility Reports, which is an amazing journal by SRM. Dr. Paulson has already published more than 250 articles and has had many awards and presentations, which he has made. So I welcome you, Professor, for joining us today at the Aspire ED Talks, which we have introduced as our very good podcast, which we have been getting great reviews about. So I'm happy that you're here, and I do hope we can take this discussion forward on preparation of the endometrium.
Thank you. My pleasure to be here with you.
Thank you. Thank you so much. I'm really delighted that you're here with us. And I'll start with my first question to you is that since there are many clinics doing freeze-all, either for rescue option, especially in patients with PCOS, or many of them are doing, freeze-all for all their cycles. Which one do you prefer doing?
Well, I think the first thing to remember is that the large randomized trial that showed an improvement in implantation rates with freeze-all versus fresh embryo transfer really only did that for patients with PCOS. So anyone outside of that group really must be considered to be an elective procedure. But I must tell you that in the United States, the vast majority of cycles are being done with freeze-all. That's probably more for convenience more than anything else. People don't want to worry about hyperstimulation, of course. And the vast majority of cycles are being done with blastocyst transfer. When you have blastocysts, there's an advantage to seeing which one actually looks the best rather than being forced into transferring one on day 5. So I think it's being done increasingly around the world, primarily for everyone's convenience.
I think so too. We want to avoid weekends. We want to have it all convenient for us. And I think it works well, so why not? So therefore, coming to the next question is that, yes, there are many protocols to prepare the endometrium. And, there are some which give you good results, some which give you a little poorer results, but there's not much evidence there. So can you let me know which are the different types of protocols you utilize and what's the difference between each one of them?
Well, the big difference really is between the medicated cycle, where the patient gets both estrogen and progesterone exogenously, and where we're not at all relying on the ovary to produce estrogen and progesterone. And then there are the natural or modified natural cycles, where we do in fact rely primarily on the ovary, at least for the estrogenic component. Those are the two big differences. And I would say that the natural cycle can be easier for the patient because in the United States, we use intramuscular progesterone for the medicated cycles, but not for the natural cycles. The disadvantage of the natural cycle, of course, is you can go right back to having to do transfers on a weekend because you don't know when the patient will ovulate and so on. So if someone says, I really need to make sure that my transfer is done on a particular day, then I advise them to do the medicated cycle.
Correct. So when we do these medicated cycles, yes, they are very convenient. They are very useful for our patients, especially when they travel from abroad and they come in. It's easier for us to do it. But with a natural cycle, what really is a concern also for patients who have got irregular periods. Do you tend to give them something to regularize their periods before you start a natural modified cycle?
I do. I really think that a low dose of letrozole helps regulate the time of ovulation. Even patients who say, yes, I always know that I ovulate on day 14 or 15, we often find that when they are in the middle of the stress of a frozen embryo transfer cycle, suddenly ovulation is delayed and the plans fall through. So we like to use letrozole. I would say even with letrozole, you still are not 100% sure that the patient will ovulate at a particular time. But we use 5 days and we use a low dose, 2.5 milligrams daily, starting somewhere at the beginning of the cycle, either on day 2 or day 3 of the menstrual cycle. Take it for 5 days and then start monitoring about 3 to 5 days after the last letrozole pill to see how the endometrium is growing and whether there's a preovulatory follicle.
Yes. So that's what you do with the letrozole cycle, that is the mild stimulation cycle. And you have a modified natural wherein you give a trigger to trigger ovulation. And that
Yes, we do use an HCG trigger. We give it in the evening, just as we do for egg retrievals. The idea being that the patient would ovulate in the morning, and then you schedule your blastocyst transfer for 5 days later at the time that in a synchronous ovulatory cycle, the blastocyst would normally form. That's right.
And then when you do the artificial cycle, how do you create that space or the right time for the embryo to be implanted?
Well, very good question. Well, the same idea, right? We're transferring. The idea is to transfer 5 days after when ovulation occurs. And we think that when you ovulate, that the progesterone rises about 12 hours later. So if we think ovulation is in the morning, that means we start progesterone in the evening. That's the day of ovulation. And 5 days later, you can do the transfer. So another way of saying it is on the 6th day of progesterone. So if the patient ovulates on Thursday, you start the progesterone in the evening on Thursday, then 5 days later is Friday, Saturday, Sunday, Monday, Tuesday. So 5 days later or 6th day of progesterone, this we have found is the best synchrony. But I have to tell you, there's a number of randomized clinical trials that have shown that there is not any difference between transferring on day 5 or day 6. Even day 7 is probably okay. So there is some margin of error, but we have stuck to the 6th day of progesterone, starting the progesterone in the evening as opposed to in the morning.
Correct. So here we have got now the plan ready as to which protocol we are going to use. Do you prefer to use the artificial preparation of the endometrium, that is the hormone-related endometrium cycle for the frozen embryo transfer? So if you're using estrogen, how much estrogen do you use? How many days do you give it? When do you step it up? Use it orally or you use it transdermally? How do you use the estrogen?
I would say that there's pretty good data that it doesn't matter what the details of the protocol are. We happen to like the oral administration, and we use 2 milligram tablets of micronized estradiol. And so we start at 2 twice a day, so 4 milligrams a day. We do that for about 6 days, and then we step it up to 3 times a day, meaning 6 milligrams total dose. And we do that until we get to about 12, 13 days thereabouts. And then we check the endometrium. If it's adequate, then you can start the progesterone. But I think there's good deal of flexibility. So it should be possible to avoid weekend transfers and to avoid a time that is inconvenient for the patient. We should be able to say, let's find a day that is convenient for the patient and for the doctor, and we should be able to hit it with that combination. If somebody doesn't tolerate the oral route, or if we're having a hard time, let's say, getting the endometrium thicker, I think transdermal is an excellent second choice. For some people, it's a first choice. They really do prefer the transdermal. I find that the pills are a little easier for the patient to keep track of, but that's a subjective finding. Clearly, there are patients who prefer patches. And when we use the estradiol patches, the equivalence that we use is that one large patch, 0.1 milligrams daily, 100 microgram per day patch is equivalent to about 2 milligrams of oral dose. So instead of 2 milligrams twice a day, which is what we use when we use oral estradiol, you can use 2 patches. They're put on at the same time. We change them every 3 days. And then instead of stepping up to 3 times a day oral, you increase to 3 patches. Both of those protocols work equally well. Of course, the critical thing is the timing from the time that the progesterone starts, is not as important as to the details of how the estrogen priming is accomplished.
But how much maximum can you stretch the estrogen to? How many days for the convenience of the patient and the clinic?
Yeah, there's good data from the 1980s, actually, that you can go 30, 35 days. I would argue you can probably go longer. Patients who have PCO, who ovulate every once in a while, probably have a follicular phase that's 3 months long, and they still manage to get pregnant. So that's probably okay. I think everybody would get nervous if we went for 3 months. So
Yes.
We typically don't go longer than that. But if you have a hard time getting someone's endometrium to thicken up, I don't hesitate to go 4, 6, 8 weeks. It's not a problem.
Okay. But would you increase the dose instead?
So, sometimes you increase the dose and it seems like it's counterproductive. I for lack of any better verbiage, and I don't have data to support this, but it seems to me that the estrogen receptors are getting downregulated, and we're not getting the endometrium to grow. So I really prefer a low dose over a long period of time. And the reasoning is that I think that is what happens in PCOS. Patients with PCOS, none of them have a thin endometrium. They're all thick. And what do they have? They have relatively low levels of estradiol that is constant. So the reason they get hyperplasia is not because their estrogen levels are high. It is because they're not ovulating and they're not opposing that estrogen with progesterone. So that has been my reasoning. And in those cases, I do prefer the transdermal, because the transdermal is more analogous to the physiological production of estrogen in terms of the ratio of estrone and estradiol. So problems with endometrium, put on 2 patches and just wait and let it happen for 6, 8 weeks, however long you need to.
Mm-hmm. We don't have patches in our country.
Mm.
The humidity, the patches keep coming out, and therefore they don't work over here. So in short, we have to use the estrogen gel. Estrogen gel, which we can apply, and that works equally well.
Yes, that's the same idea, right?
Yeah, so that's what we've been using. Do you use any other adjuvants along with the estrogen preparation which you're giving? Do you add anything more to your protocol?
No, I am not convinced by any of the data. Vitamin E and some of the other adjuvants that have been suggested, I'm a skeptic, and I don't like giving patients medications that don't have, I think, that kind of proof. So no, only estrogen and only progesterone.
No low dose aspirin or any such thing?
Well, low dose aspirin is sort of a good placebo that we've been using for the last 5 years. So yes, low dose aspirin is fine.
Okay. So when you prepare the endometrium with estrogen, when do you start the progesterone, which we have already discussed, plus 5 days or plus 6 days? And what is the amount of progesterone do you use? And which progesterone do you prefer?
So unfortunately, we have this. I will tell you that for many, many years, I used vaginal progesterone only. I think vaginal progesterone works perfectly well, but we do have a recent randomized clinical trial from the East Coast, which suggests that the patients that only take vaginal progesterone have a higher miscarriage rate. I'm a skeptic about these data, but because of that, we're stuck having to use intramuscular progesterone. So we use intramuscular progesterone, 50 milligrams once a day, and then 2 additional doses of vaginal progesterone, 200 milligrams. So it's important to know that there's probably no such thing as too much progesterone. You cannot give someone too much. This is saturation kinetics. Once there's enough progesterone in the system, the kinetics on the receptor are saturated and you don't get any further advancement. The endometrium doesn't advance faster or anything like that. So in a natural luteal phase, the corpus luteum makes about 25 milligrams of progesterone per day. 25. So imagine we are using 50 intramuscularly plus another 200 twice a day. So we are using a total of 450 milligrams of progesterone. Some of it, of course, is not absorbed. Most of it is not absorbed, but all we need is 25 milligrams a day. So I recognize that we are using way more than we need to, but I think no one wants to be stuck in a situation where you gave too little. That would be bad. And so we give them such a large super physiological dose, but there's no harm in that. So the answer, that's a long answer. The short answer is 50 milligrams intramuscular plus 200 milligrams vaginally twice a day.
So in cases when you're using the artificial protocol, in those patients, there is no corpus luteum, which is creating its own endogenous progesterone. So in such cases, would you give a higher dose or would you just give it for a longer time?
Well, we are. I mean, if there's no corpus luteum, then we're using the intramuscular plus the vaginal. Whereas if somebody is in a natural cycle where you probably don't need any supplementation, we still give them some vaginal twice a day just to give them a little extra. So the short answer is yes. In an artificial cycle, we use the intramuscular plus the vaginal, whereas in the natural cycle, we merely supplement with a little vaginal, recognizing that it's probably not necessary.
So I think keeping all these protocols in mind, what would you think gives you the best results in terms of live births, in terms of less miscarriages, or any of the success rates which you have with any of these cycles? Do you find any difference in the success rates?
Yeah, I think the data are pretty clear that there is not any difference in terms of the outcome. There are some suggestions based on large retrospective series that patients who don't have a corpus luteum, meaning the ones that take the medicated cycles, have a higher incidence of preeclampsia and hypertensive diseases of pregnancy. Because the data are retrospective and because doctors use medicated cycles for a different group of patients than they do the ovulatory cycles, I think we have to wait for the RCT to come out. Until that happens, and the difference is not very large. I think that it is the jury is still out. If you like one cycle or another, I think you should use that one. But I really don't. I'm not convinced by these retrospective studies and by the very small sort of experiments that have been done. There is a large RCT that's going on in the United States. They promised us the data last year, and they still don't have it. So maybe next year we'll have it, and then we'll all be a little smarter.
Yeah, I think all these RCTs take a long time, and we need to wait patiently for the results to come out. There's also a risk of having larger size babies in these women who go through an artificial cycle.
Yeah, this is also retrospective data that's it's mostly sort of large collections, and they're not consistent. So the first kinds of studies were frozen transfers versus stimulated cycles. So we had, on the one hand, patients who had controlled ovarian stimulation with multiple corpora lutea, and on the other hand, the artificial cycles. And now people are kind of trying to sort that out. But yes, in general, the medicated cycle medicated frozen embryo transfer seems to be associated with large for gestational age babies. But these risk ratios are tiny. These are not large risks. And again, because the patients were selected by the physician, I think we have to, I'm not convinced by those data. I'm not sure that there's going to end up being any difference.
Anyway, thank you so much, Rick, for being with us. I think we have reached the end of our podcast, though I would have loved to go on talking much more and getting more out of you for the benefit of our listeners. And thank you so much for being with us early morning for you in Los Angeles. And we thank Aspire Ed Talks also for helping us to get this Ed Talk created. And these ED Talks are totally free to access, and we will send you a recording which you can share with all your colleagues at the ASRM and in your country. And we will definitely look forward to having you more and more for many of our sessions. So thank you very much for sharing your expertise. Look forward to seeing you again.